You know, listening to Chitra is something like listening to the best debater in the world today. So if she says that a lion is as tame as a sheep, and if you listen to her for 6 minutes, you will actually think that yes, a sheep and a lion are tame animals. But here we are here for the post-laser correction, cataract surgery, and a multifocal. And I'm speaking against it. Because it's not because Chitra is there against me, but it is because of the principles of science that we have here today in front of us. And let us remember, our patient's eye is a precious eye. A LASIK has been done. The patient's eye and the cornea has been reshaped to improve the focusing of light rays on the retina, but the reshaping of the cornea has taken its toll. And in such a LASIK and in such a patient, the post-LASIK eye will be sensitive even to a dioptric shift of 0.5 or 0.75 this way or that way. These are high expectation patients, and with a high expectation patient who has achieved his high expectation in his 20s and 30s, 40s maybe, the best of distance vision he or she would always require. This was their previous goal. But when they developed presbyopia and more reading glasses, they were robbed of that power of seeing well without glasses. And they accepted it till the time they had cataract, and the distance vision also decreased over time. So now the intention for every patient who has undergone laser refractive surgery is to get back that beautiful vision for the distance. For the near, for the last maybe 20 years, they have compromised on the near vision. The drawback of post-LASIK, it's the patient's corneal irregularity. If a patient's irregularity is there, how do you think that the multifocal IOL can be as accurate as in an eye which has not undergone a refractive surgery? The reshaping of the cornea is a permanent aspect. Precise corneal shape and an accurate intraocular lens power calculation. How can we assure a patient every time? We cannot. Calculations cannot be with the highest precision after LASIK, even with the modern formula. You cannot strike 10 out of 10. And if you promise a 10 out of 10, then you are in for trouble. Vision might be permanently blurred or require an additional surgery. Are you prepared for it? Are you prepared to do again a little bit of LASIK polishing just because there has been a decrease of the Chitra is taking down notes. Thank you, Chitra, for taking down all those notes and to memorize them next day. So we have the intraocular lens power calculation, the lens selection, the challenge that we have. And let us remember, we are talking of patient satisfaction. So a poor patient satisfaction is something that is not acceptable to any of us. The structure of the MFIOL itself has evolved. But again, it is not that same aspheric structure that God gave us with our own natural lenses. There are rings, there are aberrations, and these aberrations will take a toll on a patient's post-refractive eye when it comes to a multifocal IOL. The large, and if there has been a large dioptric correction, these are absolutely no for a multifocal IOL. If a patient after LASIK has had night vision problem, it's a big red flag. And if there was a decentered ablation, definitely not a multifocal IOL. Absolute contraindication, and in post-hyperopic LASIK, the negative spherical aberration of the lens combines with a hyperprolate cornea and might diminish the quality of vision. Prior to hyperopic LASIK, these multifocal lenses, the multifocal lenses in a cataract surgery with a hyperopic LASIK is definitely not a correct thing to do. The poor quality of vision, decentration of a multifocal IOL, it can decenter. These are high myopes. There can be zonular instability, decrease of contrast sensitivity and exhibiting the night symptoms, the corneal contour irregularities, higher order aberrations, presence of irregular astigmatism, decentration even with a treatment bed. Prerequisites for the multifocal: patients absolutely happy, achieved great quality of vision after refractive surgery. If their ablation bed was fairly well centered with very little or no astigmatism, they did not have night vision problems. If any of these criteria are not met, do not have multifocal IOL. Surgeons need to be prepared for post-operative surprises in MFIOL post-LASIK. Thank you very much.
Thanks a lot, Partha. Can you stop sharing your screen? Yeah, thanks a lot, Partha. No, I mean, not for the part of the debate is over, but I was not talking of eyes. I was talking about eyes which are well operated by a capable surgeon and doing a premium IOL cataract surgery in those patients, not with complex eyes. But going back to being realistic in certain scenarios, I have this question. I would want Dr. It's not here. Dr. Himanshu to answer that question. Is not here. Now, there are times when we have done early laser treatments where there were treatments where some of them were not as so much finesse as what we have today, the eye tracking facilities and the ablation patterns. And some of those patients are also coming back to us. So Himanshu Matalia, I have a question for you here. Yeah. You, assuming there is a little unintended higher order aberrations which you see on the topography, would that deter you from doing a multifocal IOL in those patients? If the ablation is not irregular, I'm not saying that. I'm only now telling, I had answered the first question to Partha, but I'm asking you, if the HOA is showing us a little more on the eye trace, would that deter you from doing a multifocal IOL on these patients?
No, to me, HOA is a big hoax which we are throwing without understanding ourselves much about it. The aberration can arise from tear film, cornea, lens, across, and we just blame everything on one particular thing. So no, according to me, HOA itself is not a thing which would stop me to put any premium IOL.
Yes, I also do agree, though I would want to differ. I wouldn't want the audience to go back with the right take-home messages. Debate aside, Dr. Ramurthy, I'll ask you this question. If it is we know it's a complex IOL PAR calculation, we cannot take that away. When you have not achieved target emmetropia, I believe most of the challenges are because you have not achieved target emmetropia. Would you want to do a touch-up in these post-LASIK eyes?
I suppose so. I mean, I suppose if there is enough cornea available and it's a straightforward refractive error, we can go ahead and do it. I thought that Partha gave a very balanced approach. He did not say totally no against multifocals, but he defined places where he'll keep away. Obviously, if the immediate post-operative result was good and the patient was very happy right through, in topography, you see a sea of green. And I would differ from Himanshu about higher order aberrations. If there's significant amount of trefoil or coma, definitely I would not tend to go ahead and implant a multifocal intraocular lens in these patients. And now I believe with the Barrett 2K formula being available to us, especially in the reasonably regular corneas, our IOL power calculation is also quite good. And in case there is enough tissue available, if there's some amount of just a refractive error residual, we can do a surface ablation and touch up these eyes too.
Dr. Susan, if there is a little irregular astigmatism post laser vision correction, what would your approach be if you want to give a premium IOL to these patients? You have to unmute yourself.
Yeah, I wouldn't go for the multifocals in the presence of irregular astigmatism, because then you have multiple surfaces with multifocality, irregularity, and all these things. So patient may have glare halos and a lot of other issues. In that case, I might go for a more extended depth of focus lens, or for eye hands or something like that, which gives a reasonable amount of intermediate vision as well. So I think that is what I would approach, and I would tell the patient that there is a possibility of wearing small power glasses at certain distances, and that he would have to get used to that idea.
Dr. Titial, would you do anything different?
I think most of the points are well discussed. One point I like to highlight here, once we have a good patient for a multifocal IOL after laser vision correction, these patients, I've seen that they are much more adaptive to multifocal lenses in terms of the visual phenomena, which other people are going to have a tough time because they have undergone refractive procedure. They do have some sort of a visual phenomena as such. I've seen few of my patients, they are very adaptive to multifocal IOLs. They're not worried about those rings and other halos also. And I rightly pointed out, Dr. Ramamurthy, I think the higher order aberration has to be assessed in these patients. It may come from tear film or a cornea, it has to be looked into.
That means if there is higher order abrasions, more to both of you, would you put higher order abrasions is based on the abrasions, not the reasonable amount of higher order abrasion. Would you change the intraocular lens, negative spherical, positive spherical, plano? Would you do all those kind of tweaking to these patients?
Yes, true. That especially patient who undergone radial keratotomy type of procedure where entire corneal profile changes different than a laser vision correction profiles. And yes, if possible, we would look into a asphericity of lens and try to give the lens which negates the problem for these patients.
So there were different studies. Yes, Dr. Ramamurthy, yes.
So just one word as regards the choice of multifocal intraocular lenses. I'm a great fan of trifocals. I use them quite a lot. But if at all I have to put a multifocal in a case of post-refractive, I would rather opt for a EDOF concept. That is something like a Symphony or Synergy. I think they're a little more forgiving, and because of the extended depth of focus, the patients may adapt better to that.
And also the central zone is a little more. The central zone in Symphony, the central zone is a little more. And even if you have a little more larger angle alpha, that will get compensated in the central zone. Yeah. And another thing, I just want to add one small thing, Chitra, which I burned my fingers. I just want to, it may be a simple thing, but I had a patient, I put a multifocal lens, and then he was very unhappy. Then we found out that he was a post-LASIK patient. And he had done LASIK 27 years back, and he never told us. And we also never could find out. So 27 years back, he had LASIK, and he also forgot about it. And we also couldn't find out and give him wrong thing. So this is one thing which is important, because all these patients are coming to you now for cataract surgery. And every patient, I think you should ask for an history of any such procedure. We asked for an history of this thing, but somehow it got missed in this particular patient, and we burnt our fingers in that.
One last question is, Dr. Jeevan Titial, there are articles which say that intraocular aberrometry does not play a more significant role in laser vision correction to decide the true power. That's equivocal to the other formulas. Would you differ since you are doing that?
I think you are absolutely correct pointing out that apart from looking into the aberration profile of the eye, which may or may not make a significant difference sometimes, but yes, if it has a more of a corneal higher order aberration, that should be a concern. Other important thing which I regularly do in these patients is to look for the corneal surface. Apart from a ocular surface, we like to do a topalizer sometimes to see what is the corneal aberration profile in these patients. Sometimes I do a entry segment OCT to check the centration of ablation and the epithelial thickness profile in these cases, because these are very important points which may be the important factors making patient very unhappy after surgery. So 2 or 3 points has to be really looked into before we plan these cases.
Thanks, sir. Sir, I think the topography should be done for all multifocals, whether previously operated or not operated.
True. That's
topography gives a lot of information, and multifocal, all lenses, I do it.
My suggestion is eye trace, sir. If you have eye trace and you can get the higher order aberrations, and a strict no for people who got very high HO. And
Another, you have anything to add?
Yes, ma'am. Yeah, but even the simple topography would actually differentiate a centered myopic ablation from a all flat corneas, I think we should be on high alert. If somebody comes to you with say 38, 39 or 40, some people may not come out with a history of LASIK surgery done, especially females, or if they have not, disclosed it to their family members. Another thing, if they are very high myopes, you will have a very low powered multifocal, which probably even availability can become an issue.
Yes.
And your question, ma'am, about the irregular astigmatism, I feel if it's a really an irregular astigmatism, there could be an element of coma. So instead of even a IHANS or EDOF, I would prefer to put a simple monofocal and counsel the patient well, because in spite of doing a good surgery, she might end up having glare and halos. One question I had is, if at all you want to put a post-LASIK multifocal IOL, compared to a patient with a non-post LASIK multifocal IOL, will the glare and halos be double or will it be the same? Obviously, there will be some difference. So I think counseling will become even more important, especially if it was a very high dioptric correction. So the corneal spherical aberration would be somewhere around 0.9 or so, which anyways, we have a limitation beyond minus 0.27 of thickness. We don't have a choice of using a negative spherical aberration lens.
But anyway, if they are operated for LASIK, Anaga, they would be not needing that kind of a low dioptric power.
Yeah.
They've already been operated. So they are more or less every LASIK patient has undergone LASIK because they don't want to wear glasses. So the pressure on you is phenomenal that they really don't want to land up using glasses. So explaining more of all said apart, all counseling apart, but the fact is they don't want to wear glasses given a choice.
Yeah. Anyway, I think Anaga and Himanshu summarized it well.